Now, it is my great honor to introduce our keynote speaker, Dr. Josh Bamberger. A little bit about him, if he doesn't mind. Dr. Bamberger led the San Francisco Department of Public Health's Housing and Health System of Care for 27 years. During that time, he coordinated medical and behavioral health services at the Health Department's supportive housing programs, which grew from one building in 1999 to 43 buildings today, serving over 1,700 tenants. He helped establish the Housing and Urban Health Clinic, the first integrated health clinic in the United States designed to serve people in supportive housing. He's served as a special advisor to the U.S. Interagency on Homelessness. And presently, Dr. Bamberger is the interim medical director at the downtown VA Health Clinic and is consulting with Kaiser Permanente to develop a plan to end homelessness for frail seniors in Oakland. In addition, Dr. Bamberger is the Director of Health and Housing Innovations for Nonprofit Housing Association of Northern California. He's been practicing family medicine with people living in poverty since 1989, and he lives in Berkeley. Dr. Bamberger.
Thank you.
So, down will advance the slides.
Okay.
And there's a pointer.
Right on. Thanks. Good morning. Thank you so much for welcoming me here. You know, I'm a little bit out of it today. My mother called at 3 o'clock this morning saying she was having a heart attack, 95-year-old mother, in the Berkeley Hills. She's not, but took a couple of hours to chill her out. So if I act a little bit like I did after no sleep in my internship, just be glad you're here instead of in the San Francisco General Emergency Room in July of 1989. Okay. So I just, Wendy, that was such a great introduction. You know, I've been doing this work, as my bio says, for quite a while. And it's just so exciting. You know, last year when I presented to the older folk, what's the right term? What would you guys call yourself? The Council on Elderly Doing Goodness. You know, it was sort of a beginning conversation and just seeing how it's evolved over these last 8 months or so to really focusing on the individuals that we're here to help is so great and so wise. I mean, for those of us who've been doing this work for a long time, and I was at a press conference with Mark Benioff yesterday as he was announcing a $6.1 million gift to build a 53-unit building. I was sitting with my nurse manager, my former nurse manager, and we were both saying, you know, the things that feed us when we've done this work for so long is the stories of resilience that we hear in our clinical practice. So I was taking care of a patient of mine on what day is today? On Monday, and he's a guy who was in prison for 36 years, and he had just gotten out. He's in a halfway house, and he said that on December 7th he's going to go visit his mother in Cleveland, who he hasn't seen, obviously, for a very long time. And he said, you know, I'm so grateful for the care that you're giving me. My hemoglobin A1C is 6.2, and my hypertension is controlled, and all these things. And he said, I feel so blessed. And I'm thinking, this guy just spent 36 years in prison, and he's coming to me with gratitude. That's the food that gives me the motivation to do this work. And for those weird people out there like this who, you know, don't mind hearing the horrors of suffering because the food of the resilience and joy is so much more compelling, then this work will get done. And for those of you who just get overwhelmed by the sorrow, you know, take some Prozac and call me in the morning. But it's hard to sit with it. And there are enough of us out there who really groove on the resilience and are just overwhelmed by the strengths of the people who are so much stronger and more capable than I could ever be. And that's just really inspiring. And that's, you know, as your 6 stories show, and I think that's the place to start. So starting there with my patient, as you can see, this is a guy who I took care of in San Francisco, and there are some compelling parts about this picture. You'll see that he has 5 bands on his arm from admission to the hospital, because he's an older man who lived in the Tenderloin and had some cardiac problems, and also was exposing himself to cocaine quite frequently. So he'd go into the hospital, and they'd admit him often to the intensive care unit, and then he'd leave against medical advice, and he did that 5 times in a week. And each time he'd go in, the thing that sort of is amazing about this picture is the nurses wouldn't bother to cut off the admission bands when you go to the hospital the next time, because they weren't really seeing him as a person. You know, it's just there, and he's having this problem, and they treat him the way they treat him, and then he bolts and so on. But once we housed him in permanent supportive housing at Mission Creek, which is out by AT&T Park, he stopped going to the emergency department. He lived there for the rest of his days with autonomy and freedom, and wasn't sick. So that's sort of, getting back to where we need to be. These are the people who deserve our love, our care, our advocacy, so that by the time we finish this effort with Kaiser in the next few years, no one over the age of 50 in Oakland will spend a night on the streets. And that's our goal, and I think it'll happen. And I really feel that the inertia is there. So let me give you some sort of background to hopefully pump you up to this effort, and then I think the rest of the day, which sounds really productive, will help to concretize these ideas, and we'll get this thing done. So just some background on Oakland senior homelessness, and this is really taken a lot from Margot Cashell's work, who, as I understand, you heard from a couple years ago, and she's awesome. She and I met yesterday with Mark Benioff up at the top of Salesforce Tower. That's a whole other story I'll tell you about sometime. It's pretty fun, the big man himself. So one thing that's quite remarkable about Oakland's homeless seniors is about half of the people who are homeless and over the age of 50 in Oakland did not become homeless for the first time until they were over the age of 50. So when you think about, the 1980s, when we had these documentaries of, bag ladies carrying all their stuff through the streets of New York, you think of folks who've been homeless since they had their first psychotic break at 17. Half of the people in Oakland are not like that. They are people who have built Oakland, but now can't live here. So that's a very different type of homeless population than we think about, at least in terms of serving people with severe and persistent mental illness and substance use. But yet we need to serve these people just as much as we need to serve everyone else. So that's data point 1. The second thing is that half have been homeless for a long time. So embracing the heterogeneous population of homeless seniors in Oakland is really important, and really brings to one of the main points I want to leave you with today is we have to have the right treatment for the condition. I understand that pathologizes homelessness, but it's easier for me as a medical person to put it in that frame, that everybody needs the right home. And each home is different for each person. And we have to create a system where we assess each person individually and then use our clinical and collective wisdom to offer the right housing to the people so that everyone can be off the streets with the least expensive, most autonomous housing they can have. Doing pretty good for being sleep deprived. All right, let's keep going. Another important data point is that African Americans are much greater overrepresented in the homeless population than the general population here in Oakland. And this actually goes across pretty much every city in the United States. Kind of blows me away. That if you look at the percent of people who are African American in the general population, you multiply it times 4, you get the percent of people who are African American in the homeless population. And if you look at people who are living in deep poverty, and you find out the percent of African Americans in that population, and you multiply it times 2, you get the percent of people who are African American in the homeless population. So if you think about that, there's something else going on here besides poverty, right? There's clearly racism and discrimination, redlining that has led to a crisis among African Americans in the homeless population that isn't just about healthcare, isn't just about developing services, it's also about justice. So if we're going to make headway on this, we have to embrace our legacy, and I'm really looking forward to this incredible trip I'm taking at the end of March with folks from Glide Church to the Legacy Museum in Montgomery, Alabama, with 40 homeless people from the Tenderloin. And that's going to be almost too much for me, probably. And in Oakland, there's a very high rates of unsheltered people. So if you say, oh, I was in New York last week, and there were no homeless people in Times Square, why can't we be like New York? And you know how many homeless people are living in shelters tonight in New York City? 56,000. So we don't want to be like New York. We want to use this moment in time when people are unfortunately suffering on the streets to motivate our politicians to do the right thing, which is permanent supportive housing, not shelters. Because if you do transitional housing or shelters, it's to where? So we need to build more housing. Or find it. Okay, so that's the background in Oakland, and I'm happy to take some questions and flesh some of those things out later. But it really is strong motivating to what we need to do. It's clear. Again, talking with Benioff yesterday, he started this preterm birth initiative at UCSF. And we don't really know why black and brown women have rates of low birth weight babies at much higher rates than other populations. We just don't know the science of that, and it's really vexing and terrible. But we know how to take care of the problem of homelessness, which is a home. So we don't need to do a lot more science. Nonetheless, let's get some data on what supports the idea that we should be doing this. So first of all, this is a study we did in San Francisco in the 2000s, the noughts, where we looked at all the people in San Francisco who were homeless when they had their first HIV positive blood test, okay? And we followed them for 5 years. And what we found is that the people who were housed, which is represented by the dotted line, were much less likely to die than the people who were homeless at the time of their HIV positive diagnosis, right? And you can see that that separation in what's called the Kaplan-Meier curve has the red line showing people dying more often than the dotted line. And this was a time when we didn't have a lot of supportive housing that was out there, and we weren't doing a lot of targeting of people who are sickest to prioritize them towards housing. Then basically what we did is vaccinate the tenderloin with housing by going out purposefully finding all the people who are homeless and HIV positive and prioritizing towards permanent supportive housing. And in the next 5-year period, we see that the death rates between these two populations was not different. In other words, we took this population, housed them, and stopped people from dying at a higher rate than they would if they weren't housed. So that's really actually, you may not realize how rare these kind of data are to show that you can actually change the death rate of a population by something. You won't find any pharmaceutical out there that can come close to this kind of impact on death. So this is one of the few studies actually that shows that housing reduces mortality. And this is my favorite slide. It's not very good research, so I probably couldn't get this published in any particularly decent journal. It's what I call BART research, because I did it between Powell Street and El Cerrito Plaza one day, where I just looked at all the people who were in our 11 buildings, and I knew how frequently they died in each building. And then I used the Josh Bamberger scale of beauty to rank these buildings from most ugly to most beautiful. And it's not replicable in any other setting. And I found that the buildings that were least beautiful, like the Windsor, which is in the Tenderloin, it's an SRO with shared baths, had a rate of about 7 out of 100 per year died. And then in a beautiful building like Mission Creek, only 3 out of 100 died per year. And this is over a 5-year period. And there's actually a statistical correlation in this line that goes from least beautiful to most beautiful. Now, I love this slide because it really is what motivates me and sort of gets my juices flowing. Because there's something magical about beauty. There's something that is inexplicable as to why beauty and autonomy and self-determination should make people live longer. And these are folks who are living with cancer and heart disease and HIV, things that theoretically should just kick their ass. But when they're moving indoors to a beautiful place, they're much more likely to survive for a longer period of time. What is that about, right? What makes that happen? And I think when you are interacting with your kids or your mother or your friends or someone on the BART, and you realize that with kindness and dignity and respect, it matters. It matters not just in that interaction, it matters in how long we live. And the beauty in housing really, I think, makes a difference. So when Bonnie is bringing the Alameda Point Collaborative to market, and it's going to be this gorgeous building overlooking the bay, and 93 people in homelessness to go there, that's going to be extraordinary. And it's also cheaper to house people than to leave them on the streets. So this is a study, we did a randomized trial of permanent supportive housing in San Francisco. We took 81 people who were randomly assigned to housing and 81 people who are not assigned to housing, who we didn't go out of our way to house. We didn't get in the way of housing, but we just watched them. And the blue line represents the people before the group moved into housing, and then the brown bar is the how much these folks cost after the first group moved into housing, right? The second group, the control group, didn't move into housing, but the timing starts when those other guys are all moved in. And you see that the cost to serve the people who moved into housing dropped dramatically from about $30,000 a year down to about $12,000 a year. And then the people who didn't move into housing actually became more expensive. So if you want to use our healthcare dollars efficiently, effectively, and appropriately, spend it on housing. And for those of you who might have noticed, the Secretary of the Health and Human Services gave a speech about 2 weeks ago saying that he believes Medicaid can now be used for housing. That like, boom, whatever hair I have left fell out, but I don't know if it'll actually happen, so we'll see. And then the other thing you'll notice in this graph is that the gray bar shows that the people who are not in housing actually got less expensive in the second year of the study. And in some ways, the control group proves the hypothesis as much as the treatment group does. Because if you see in this group, in year 3, 41 of them moved into housing. So they proved the point by having a reduction in healthcare costs because they moved into housing, but then 18 of them died compared to 7 in the treatment group. And as we all know, the Logan's Run theory of public health, if you know that cheesy 1970s movie, it's cheaper to be dead than to be alive. So if we, want to really save healthcare costs, we know how to do it. And then what's the perfect housing? So, and that was not serious, right? You get that? Okay. I didn't sleep last night. So this is a picture of Mission Creek, which is a building, as I mentioned, where that guy lived his remainder of his days. This is a mixed supportive affordable housing just for seniors 62 years old and older on the bay next to AT&T Park, overlooking a beautiful part of this world. In this building, nobody dies, and their healthcare costs, I'm not kidding, in the first 7 years after these people, most of whom moved in from Laguna Honda Hospital, who are very high users of the healthcare system, they actually used 0 days of inpatient care in the first 7 years that they were there. So if you want to start crafting the perfect place, for example, Alameda Point Collaborative, you have a place that's mixed, affordable, and supportive. It's only for people who are seniors, and you have enriched on-site services, including a day health program. There you go. There's the model. That's the one that's best. Can you do more of that? Definitely. Is that the only model that works? Definitely not. And does everyone need to be in a place like this? Also definitely not. But of all the buildings I've evaluated, this is the one that outperforms them all. And then lastly, a slide that is also not particularly robust or replicable data, but I looked at the move-out rates among a few buildings that I worked in when we were originally placing people in units where we didn't prioritize people by by healthcare, and we didn't match the right housing to the right condition. So it's basically a unit would come available, whoever was top of the list would get placed in that unit, and we'd move on to the next. And that's represented by the blue line. And what this is the move-out rate per year in buildings that didn't have prioritization and where there wasn't matching going on between needs and services. And you see an incredibly high rate of move-out, right? In the Star Apartments, you have a 30% annual move-out, which for anyone who's done supportive housing is brutal, because you got to flip those units. The units are often trashed when people move out. And when people move out, it's not like, oh, see you later, I'm moving to Virginia. It's like, big mess. So that is a bad outcome in supportive housing. You do not want people to move out. So when we started prioritizing people, the move-out rates dropped dramatically. And I'm really worried here in Oakland that we're just not paying attention to these data. So I'm going to hammer this point home, that we really need to assess each individual, ask them where they want to live, but also encourage them to be in the right place that we think they need to be in. And that's a balance between beneficence and autonomy, right? I won't deny that I'm exhibiting some of my preferential values, but I think that if we only believe in autonomy, we're going to miss out a lot on efficiency. I'm throwing a lot of words out there. I hope that makes sense. I'm happy to talk about it more. What is supportive housing? Just to sort of level set. So it's affordable. So the difference between affordable and supportive, right? All is affordable, usually a third of someone's income. There are on-site services, and these can range from having an on-site nurse, psychiatrist, primary care provider, to, well, light touch case manager. The Seneca Hotel in San Francisco has 260 residents and 2 case managers, so that's the one end of the spectrum, and the other can be a place with like 25 tenants and 3 case managers and an on-site nurse. So they can really range. It's permanent, so you never have to move out to a different facility until you want to. So the rental support has to pay for the operating costs indefinitely. It can't just be a short term, because where are you going to go to next in this high rent, low occupancy world of ours? And it's housing first, harm reduction housing. Now, that means that people move into housing whether they're using drugs or they're mentally ill and not taking their medications or taking their medications. But that doesn't mean that all housing is the same in terms of the harm reduction spectrum. One thing we've also failed at pretty badly in San Francisco is having one-size-fits-all harm reduction housing, where you can use heroin, cocaine, alcohol, not take your medications in every building, or you can be abstinent and take all your medications in every building, but there's no separation based on the harm reduction spectrum across buildings. And we're really doing a disservice to many people by not having clean and sober housing, by not having wet housing where people are actually dosed with alcohol, by not having a place where people can form a community that's a sober living environment. We need to have that range, and we need to give people an opportunity to choose where they want to go in and support them if they change, because we are not always the same. We change every day. So here are some examples from around the country of places where these solutions, this all has been put together to succeed. So the first is in Portland, Oregon, where you can keep it weird. And here, for those of you who aren't following sort of Medicaid rollout history, sort of the Affordable Care Act arrived in Oregon about 6 years before President Obama pushed it through the Congress. So basically everyone in Oregon was able to access health care about 6 years before the ACA rolled out. And what that created was this opportunity where there was this capitated existence where the entire state basically got an amount of money from the government up front to pay for health care. And they could spend that on penicillin or immunizations, or they could spend it on housing. And that was great, but they weren't able to get around the Medicaid regulations to use it for housing. But what they were able to see is that all these folks who were uninsured and where the community benefits that was an obligation of nonprofit hospitals was being used for their uninsured care, all of a sudden was getting revenue instead. These people were able to bill, and the community benefits couldn't be spent in the way that they had previously done. So they were kind of on the hook to maintain their nonprofit status. So 6 hospitals, actually 5 hospitals and 1 healthcare system, pooled their community benefits into one donation to Central City Concern, which is the largest provider of supportive housing in Portland. And they made this 365 units building that has enough equity, and again, I'm getting into sort of the weeds of how you do affordable housing, had enough equity, and Linda will tell a lot more about this as we go, and she's way better at this than I. The equity was enough so that the tenants don't have to pay, the landlord doesn't have to take any more income than what the tenants can provide. So it doesn't have to be a local operating subsidy. So that was a huge lift forward. 365 people ended homelessness, and the government doesn't have to pay for it any more than this initial investment. So that's a model that is replicable, and one thing that Kaiser has looked at, Kaiser was one of those 6 hospital systems. And they're looking at very seriously here in Oakland to use their community benefits to make a major leap forward to ending homelessness for frail seniors here. And then some seniors are too sick or too disorganized to be able to live very well in independent housing. So we need more structure that isn't a nursing home. So that is a thing called a boarding care or residential care facility. And in San Mateo County, they did this amazing thing where they are able to use their Medicaid dollars to pay for board and cares up front, because it's a capitated single payer system, which again, we can get into some details. And they've now moved about 300 people from nursing homes into board and cares and independent housing, reducing costs dramatically and giving people the services and the autonomy they need. So it's a single-payer, low-income system throughout the entire county, and they're able to use this matched funds to be able to move people out. Now, AB 2233 was something that was going to expand this strategy called the assisted living waiver throughout the entire state and increase the number of slots for the assisted living waiver to 18,000 across the state from about 3,600 now. Unfortunately, Jerry Brown vetoed that after it passed unanimously from both the Assembly and the House. I don't understand why he did that. But with Governor Newsom now about to take this on, I think we have to reintroduce this, because for some of our seniors, supportive housing isn't enough. And we have to have a funding strategy to move people from living in nursing homes like this to living more like this. All right, how does this all get done? So government isn't nimble. Government isn't particularly able to respond to the needs of the people quickly and deliver services efficiently. Nonprofits often are better at that, but they're less stable. So how do you create a balance between the stability of government and the flexibility of a nonprofit? So in Los Angeles, the strategy that they used is this thing called a flexible housing subsidy pool. Now, this is the number 2 of the take-homes for today. One is matching the right person to the right place. The number 2 is we have to create a flexible housing subsidy pool or housing coordinating agency here in Alameda County so that we can successfully take government monies and get them to where they need to go, and also have a place for all the philanthropy that we're going to get, partly from Kaiser, to be able to end homelessness for frail seniors. So this is how a flex pool works. You have a pool, it's green, or blue in this case, so where you put the money, and what comes into it is general fund, so we can get the county general funds to go in there, or the city perhaps. Other things that go into it is we can get Medicaid dollars, especially mental health Medicaid can fill the pool. Philanthropy, such as community benefit dollars. Hospital community benefits, which is another type of philanthropy, a little redundant. Contract from managed care, so Alameda Health Alliance, for example, could fill the pool. Whole person care can fill the pool. And the newest Medicaid line of business, health homes, can fill the pool. So here's a big pot of money, and we need to sort it to the right place, to services, to operating subsidy, to landlord relations. It needs to be flexible, responsive, and create the housing, the diversity of housing stock so that no senior spends a night on the streets. That's how they did in Los Angeles. And what did they spend their money for? They spent it for, what does that thing say? Intensive case management, housing locator services or landlord relations. Development costs, believe it or not, they were able to use some of this money for equity to build new supportive housing. On-site services. And what did they do with that? They have a pipeline of 3,753 new units. How do you like that, Linda? That's more than you got going on, but not a lot more, actually. So 3,753 units just for supportive housing, and another 6,000 market rate scattered site housing. So that between their various lines of business, they now have 10,000 new units of housing for homeless people in Los Angeles through using this flex pool. Very efficient, effective, nimble, responsive, the things that we need to do, combining government and nonprofits into one strategy. Works really well, very exciting. And I look forward to seeing this happen here. And it makes beautiful buildings. So why aren't we not a house of fire? It's a bad analogy. Why are we not moving very quickly towards making more supportive housing for seniors? Well, there are lots of things that get in the way of housing policy and homeless policy in this country. A lot of myths and a lot of reality of differencing of opinions. So one thing that happens, at least until the new Medicaid director, the Health and Human Services director said this, they said that housing is not healthcare. Just not what we do in healthcare. Another thing is that we don't want to take care of these lazy homeless people when there are these hardworking Americans who spent their entire life just trying to make scrimp and scrape to be able to make their rent. Why should I be giving a handout to a drunk? If you build it, they will come. That's a big myth that people will come from all over the country. They'll hop on a bus in South Carolina to come get housing in Oakland if you build more housing. We don't want these folks next door to us. Especially, we don't want young people who are using heroin next door to our kids when we're trying to get our kids to school in the morning. And it's just not fair. It's just not fair that we are going to spend our dollars on homeless people when they just haven't earned it. So these are some of the things that get in the way, and I'm sure that some of those resonate with you, and some of you think that that's awful. But it's all our values, and it gets played out in the world of trying to get this stuff done. So recognizing this and not being able to beat down these myths or beliefs, I pivoted about a year and a half ago to focus just on seniors. Because if you take each one of these, they really don't apply nearly as powerfully, at least in the political narrative, to seniors as they do to the general population. So many people feel that having a building full of seniors isn't as scary if it's next door. We don't worry about people getting back into the workforce if they're over 62 because we expect them to be retired. So we're not holding this standard of like just taking a handout. Seniors, for the most part, really truly aren't very mobile. Most of us seniors, I'm 56 now, so I not qualify, are not wanting to leave our families, our friends, our kids, and go to another place and start anew. So the mobility of seniors is less. So the if you build it, they will come problem is not believed as much. And as people get older, they get sicker, believe it or not, we do. And the healthcare system is much more likely to embrace them as a population that they want to spend their dollars on. So all these things sort of wrap up as to why it creates this much stronger moral narrative around seniors. And this is one of the reasons why Kaiser bought this idea, that they want to end homelessness for all frail seniors, not just in Oakland, but in all of their business centers. So just wrapping things up and then having a little time for questions. This idea that housing is a medical intervention, it's true it pathologizes homelessness perhaps more than it needs to be, but it works well in my mind. That if we had a way that we could actually write a prescription for housing and get it filled somewhere, maybe at an affordable housing developer, we could successfully prioritize housing to the right place. So when you go to your doctor and you say, I have a cold, I want antibiotics, I hope your doctor says no. Because antibiotics don't help with viral infections. So we are used to, in medicine, prioritizing the right treatment for the right condition. And having a little bit of that value enter into the housing system, I think, is a good thing. Not too far, because doctors don't always make the right choices, as Tuskegee can tell us. But we do a lot of things right, and we have to embrace our mistakes and figure out how we can make headway by using this way. Focus on who we have here in Oakland. So 4 of every 5 people who are homeless in Oakland are African American. Half of the people who are homeless in Oakland are over the age of 50. And there's just a great opportunity to take this population, which is big in percentage of all the homeless people in Oakland, but actually not that big in the big picture. And a guy like Mark Benioff can come along and write a check and end homelessness tomorrow. It's not that unreasonable, because there is an incredible amount of wealth. Mark Benioff, who owns Salesforce, has $6.8 billion of personal revenue. He's the 265th richest person in the United States. What the hell? There are 264 people richer than he. So there's a lot of money out there. We have to be coordinated in our efforts. We have to be able to get everyone in line so this perhaps artificial conflict between the city and the county needs to go away. When I've met with many of the people here in this room, everyone says the same thing. We all want to do the same thing. We all want to end homelessness for frail seniors. This is something we believe in our hearts. It's what we're proud of when we get up in the morning. It's what we tell our kids we want to do so they don't have to read about homelessness. They want to read about homelessness in the history books. But we're just not aligning ourselves. We need to have this focus, and I really do believe that this effort that we're in the midst of now can bring us all together, because you're all saying the same thing. You just don't know it. And then we need this focus. So our leaders, our mayor, our county administrator, our supervisors, we all need to focus on this issue. We need a success. We need that trophy on our mantelpiece, and the trophy is going to be ending homelessness for frail seniors. We need that motivation. For those of us who've done this for 30 years, we need a win. You know how good it felt, right? When the Warriors win the NBA. That feels good. It makes our whole city feel better. We need this now. And with this win, we can then have that overflow to other populations as well. But we just need to focus for now, get a win, and then move on to other populations that are, I think, equally deserving, but harder to define. So that's all I have for these slides. And I just want, again, to leave you with this idea that this is a problem that it's the problem of our time. If we can solve homelessness for frail seniors, we can see that we have delivered on what many of us feel we're on this earth to do. is to create community, to create equity, to give people the chance that they can thrive in the way that we all deserve. And what's so exciting about this time between philanthropy lining up and healthcare lining up and government getting focused on this and having incredible leaders here in Alameda County and the city of Oakland who truly understand this issue down to the very nitty-gritty. We're at this time where this can happen. And I truly believe that in the next, really, year, we could have a plan so that no one over the age of 50 spends a night on the streets. And I really look forward to being part of that effort with you. Thank you. I think I talked too long, Wendy. Do we have time for? Okay. Thanks. Oh, wow. All right. Uh-oh. Now I have to answer questions.
Hi. Thank you for your presentation.
You're welcome.
You mentioned Mission Bay.
Mission Creek.
And what was the racial data on that?
So what's the racial breakdown of Mission Creek? You know, I'm not exactly sure. I don't have those data in my back pocket. What was interesting is that building has 150 units. 50 were set aside for chronically homeless adults, seniors. Mm-hmm. And I make a guess that about 40% African American, maybe 20% Latino, and the rest other. But what's interesting is the affordable housing 100 units are all done off a wait list, a lottery, rather than having people who are selected for their clinical needs. And my guess in San Francisco is that's probably about 90% Asian American, because when you populate low-income wait lists in San Francisco, the majority are hardworking, low-income Asian elders.
So who are the affordable housing developers? You look at the degree of development in Oakland, has nothing to do with affordable. So who are the affordable housing developers that you mentioned at the end?
No, they're out there, man. Like Balsi, Christian Church Homes. I mean, Linda knows them much better than I. Saha. There's some really fantastic mission-driven affordable housing developers here in this county. You're not lacking for skill and motivation and mission-driven housing. There's not a bunch of for-profit people out there in this sector. So, you know, others like Mercy Housing, Bridge, the bigger, more, would have a larger footprint, Human Good. Those are all out there. But I think that, you know, no one does it better. I think, well, I'm sure they would say differently. They all do a pretty good job. And I think that some come out with more beautiful housing, some less. But I think that the challenge is that it's hard to bring these buildings with 7 different funding sources together to market. But again, with the county leadership here, I think that there's a lot of opportunity. And just talking to my affordable housing friends who are out there looking at the national scene, they're like, Alameda County is a hot place to be right now. This is a place that things can happen. And that wasn't the case before we voted in A1 and other leadership changes that have happened recently. So it's a pretty exciting time. I hope that answers your question. There's another question.
I have a question.
Yeah.
So I run a nurse case management program for older adults, and a lot of ours, they're housed, but housed inappropriately. So with this initiative with Kaiser of ending homelessness for frail elders, what about those people who are inappropriately housed? Is there kind of a plan for that?
Yeah.
I was just in an APS multidisciplinary team just yesterday talking about this very thing about independent livings and how they're such an important part of the housing stock, but it's really people are not independently living or able to independently live in those situations, and there's a lot of abuse and neglect as a result. So just wondering.
Yeah, I think that's a really important point because, one of the things we're looking at with our initiative is to get 515 new units or 550 units focused on frail, homeless seniors. But we're not necessarily talking about 515 new units. So we have to be careful that we don't just prioritize units towards homeless people and leave out low-income others who are, from my perspective, all equally deserving what we all have as a human right, which is a home. So it's tricky to do that. The assisted living waiver is an out from that challenge that I think we really need to keep our eyes on much more focused than we did last year. I really think that Governor Brown would have signed that if we had been a little bit more focused on our advocacy efforts, because there was no harm. This is a cost-neutral expansion. So it was just why didn't he sign this thing? So that could have brought 18,000 new slots of assisted living waiver. 2,000 or 1,500 of them could be here in Alameda County for people like you're describing, who don't have the capacity to make their 3 meals a day and could live in beautiful places where they have a lot of independence, but they have someone who's giving them the medications every day and of cooking them 3 meals and helping them to perform their activities of daily living. So I think that's a significant challenge out there, and we have to be careful not to take from Peter to pay for Paul, or whatever the right statement is, and we have to also get a win. So these are the balances that are out there, and right now I think that getting a win around no one spending a night on the streets who's over the age of 50 is a good focus. But it's very reasonable question, important, yeah. Hi.
Oh, yes, okay, hi, my name is Rebecca. I think we would be more supportive of the homelessness for seniors. It sounds good, their rent being not more than 1/3 of their salary, but you have seniors that are in their homes that they're paying 2/3 of their salary. You're not showing how the seniors that are in their homes, it's like you're creating homeless seniors. You're solving the problem on one end, and you're creating it on the other end. How do you solve the problem at the same time for seniors that are in their home to be able to stay in their homes? Because we don't qualify for nothing. We make $1 too much for food stamp, $1 too much for Medicare, and we're paying a larger portion of our income, fixed income, to just housing.
Right. I think that's a very compelling point. In 1972, the amount of money that the federal government spent on affordable housing was 8 times the amount they spend on it now. And the population of seniors over that time has tripled. So we are, 1/18 the amount of affordable housing resources that the Jimmy Carter, Richard Nixon administrations were making available to us. So if you want to see where the real harm in our country is, it's not hard to see it inside the Beltway, right? The federal government is not attending to poor people. How can we fix that here in Oakland? How can the tail wag that dog? It ain't easy. And the crisis of homelessness right now is so extraordinary that we need to attend to that at the same time that we get Trump out of office and we get people in who are willing to expand affordable housing, because we are not delivering on our societal responsibilities of having adequate housing for people with low income. It is way below where it needs to be. The good news is, as I mentioned, there are a lot of these mission-driven affordable housing developers that are out there just waiting for the opportunity. And this one thing around the opportunity zones, which actually is part of the Trump tax package, could be an opportunity for getting a lot of new money in, and I'm not going to get into the weeds of that because I'll be really talking about things I didn't learn in medical school. But there's opportunity for getting people to avoid paying their capital gains by investing in affordable housing in Oakland as well. But your point, I think, I don't want to dismiss your point as being valid. And yes, we have some work to do. And I really look forward to doing that with you.
I have a question about, I like the idea of matching people to the appropriate housing option. My question is, what type of assessment tool would you use to differentiate that?
It's called a conversation. Yeah, I'm kind of burnt out on tools right now. I think that we need to have, so my direct access to housing program in San Francisco, we have a nurse. She listens to the stories from case managers, and if that's not sufficient enough to really get a sense of what somebody needs, then she goes and sits down with them and says, what do you want? Where do you need to be? And then also looks at their medical chart and really tries to match it. It is not fast and quick and easy and one size fits all, but it also gets to the magic of what medicine is all about, which is connection and relationship and understanding where people are. So I think starting with a screener is fine, because some people can differentiate pretty accurately into different buckets. But once they're in the I need housing bucket, which is pretty much everyone, then we gotta start assessing them more thoroughly. And I know it's a resource issue, but that's, I'm a family doctor. That's where I lean. and I apologize, but I also like it. Yes. Oh, sorry. Sorry. I can't say. Oh, hi.
Hi.
She's got the mic.
My name is Denise, and I work in an area called Aging and Adult Services in Alameda County. And I work directly with seniors that sleep in the bus stop. And I see seniors that have been raped, beaten, and abused. More so in North Oakland than I've seen downtown. Right here in front of City Hall. I was just wondering about the idea that New York has with their transitional housing.
Shelters.
Well, it's not necessarily shelters, it's transitional housing.
Shelters.
Where they can live up to a year as they continue the housing search. Because what hinders people in Alameda County is the waiting list. And the gatekeeper is, do you have HIV? Are you disabled? There's different things to keep the gate. And it happens all across Alameda County. And sometimes they do get housing, and when they move in, they pass away. Then you have a group that's disabled, or you have a group that is drug addicted. And you said earlier that the prescription a lot of time is housing. It helps. It does meet the need. I was formerly homeless and had a job prior to that, and I did go to school, but that's what happened to me. So it made a big difference, and I'm still alive, but I was almost gone by the time help came. So what I'm saying is, why can't they provide transitional housing, not just for 65 or 62 and older, but for those that are living in the street, where you could separate people that just got out of prison from people that just got kicked out of their house because they can't afford the higher mortgage or rent. That's what I'm seeing, people that are being in the street that were living in a home, but now all they have is an option is an SRO, and that's with a mixed population of people, and that's enough to kill the person. They're already struggling and sick when they get in the situation.
It's a very compelling story. So the city of Oakland just recently purchased the Grand, which is going to be like the second Henry Robinson's. That's going to be another, 75, 90 units of transitional housing to do exactly what you're describing for people who need to be stabilized with enriched services so they can be adequately assessed for permanent housing. But the big answer is more housing, the right housing, and diverse housing stock that can serve people like you who have a lot of resources, or people who are a lot sicker, who need a lot more services on site, and matching those right people. So I really do believe, and I'm not just Pollyannish about this, I really do believe in the next year or two we can have adequate housing stock to serve all those folks who are living under a bus stop, and have it with the right housing. And I truly believe we shouldn't expand our shelter population very much, because otherwise the politicians are just going to do what they did in New York and go get reelected without making any real solutions.
Good morning.
Hi.
My name is Cecilia Cunningham. I'm really concerned about why we're not trying to get the nonprofit organizations and the philanthropists to help us with this housing crisis, because something should be done. We need to get the word out there to every last one of them and let them know that we need help.
Absolutely.
And it will cut down on our expenses for housing. You see, we got to figure out some kind of way to get some of these things done pre bono, and still trying to figure out how we're going to pay for this and pay for that. Because we got a lot of nonprofit organizations out there and philanthropists that can help us. But we got to get the word out to them and let them know we need help.
Absolutely.
Right now. Thank you.
You're welcome. Well,
And I'm afraid that I have to...
let me just quickly respond to that. I mean, so there are these philanthropists, including Kaiser, that are out there to do this, right? And I think you'll be hearing very soon about a major involvement of Kaiser's philanthropy to make a huge impact on Oakland. But then there are other philanthropies that are out there. The Chan Zuckerberg Fund has a lot of money. The Silicon Valley Foundation all have a lot of money. Benioff has a lot of money. As I said, there's a lot of money that's out there. And I do believe, because of your work and you standing up there and saying those kinds of things, people are listening. This is a change. This is not 10 years ago when I've been doing this stuff for a long time. We didn't have philanthropies lining up to write these big checks. They do want a return on their investment. They want to know that we're measuring the right thing. We want to make sure that we see the numbers getting fewer. And we can do that. But there is the money out there, and I truly believe that this is a time to capitalize that. And by having Kaiser make a leadership on that here in this city, my hope is that it'll be a snowball across not just Alameda County, but throughout the entire country, to see that this is something that not just philanthropy, but it's the responsibility of the healthcare system to give me what I need to treat my patients, which is a home.
Thank you, Joshua Bamberger.